All good?
Yes.
Okay,
Oh,
great. Yeah, thanks very much, Steph. So, yeah, part of the role that I've got in terms of responsible research, innovation, and ethics within Chai is to sort of really try to connect Chai or help, with Niccolò Tempini, who's the lead on this at the University of Exeter, to try and connect Chai to sort of wider regulatory and policy developments, not just with a view, obviously, to informing practitioners about what the developments are, but as a way really to sort of engage Chai with this wider ecosystem, and hopefully engage causal AI practitioners and AI to practitioners more generally regarding healthcare with this sort of wider policy and regulatory ecosystem, because it is a still sort of forming and fast developing area. And it is therefore one in which practice or practitioners can make a contribution, I think, to developments in this area. So, with that in mind, I've prepared this as a sort of survey of the state of the field, fairly high level, looking at the regulation of healthcare, regulation of AI, or sort of new developments and new governance and regulatory approaches to AI in the healthcare sphere, but also within the general context of looking at some of the developments that have, in regulation more generally, and thinking about regulation and governance more generally, and how healthcare regulations fit into that, and AI regulation for healthcare has fit into that as well. So, and a little bit at the end. So after talking about regulation, some of the complexities of regulating AI, and some of those changes in general regulatory approaches, some of the regulatory challenges posed by healthcare AI, and then the regulatory responses to those. I want to talk just a little bit at the end about some of the potential contributions that causal AI might make, and some of the opportunities and prospects that we might have through Chai, whether you're already involved in Chai or whether you might want to get involved in some of the wider Chai ecosystem, because we're sort of very keen to engage people from outside in our activities and programs as well. So I'll start a little bit by talking about sort of what regulation is, because it can take many different forms. It's often set down in legislation, sort of specified, what is being regulated and how, and what bodies are involved in regulating it. And that will often set down, for example, the ways in which a particular technology or process or product is regulated. So, an example would be, for example, a horizontal versus sectoral approach. A horizontal approach would be where there's kind of general regulation of a particular technology across all the different sectors it's used in, versus a sectoral based approach, which is one where it's regulated in particular spheres of activity. So, for example, in the example of AI, the new EU AI Act is very much a horizontal act that covers AI in its many manifestations, versus a sectoral approach, which is being taken, for example, by the UK government, whereby there will be a general set of principles set down by government and possibly in legislation, but it's up to individual sectoral regulation, i.e., finance, healthcare, and so forth, to actually implement those, in a way which is appropriate to the context of that particular area. Um, and often regulation is risk based. So, there'll be a sort of stratification of the different possible risks of a particular activity or product, and regulation will take place accordingly. Now, I'm going to use two terms here across the course of this session: governance and regulation. I've sort of embedded regulation here in terms of governance being the sort of like setting out of a system, distributing resources, administering out that system, and regulation being sort of guiding events and activities, setting rules, procedures, and boundaries. But they very much, you could do it the other way around. They very much affect each other. The way in which things are regulated affect their governance, and the way in which things are governed affect their regulation. So, as set out often in legislation, there are particular regulatory bodies. For example, Medicines and Healthcare Products Regulatory Agency for medical devices and pharmaceuticals in this country. And I will say I'm mainly going to talk about the UK context, but I'm going to point to other contexts as well where appropriate. There's the institutional sectoral design, so the way in which a particular domain of activity is set out. Who actually regulates what, who is involved in implementing things. What are the sort of areas of redress for consumers or other bodies, to sort of, if there's a problem or complaint. As well as this kind of formal type of regulation that's laid down in legislation, there'd also be professional guidelines, standards, and norms that doesn't have the force of law, is not set down by a regulator, but might be set down, for example, by professional societies, royal colleges in terms of medicine and healthcare. It might be it might be journals. Standards of reporting, if you want to actually get published in a journal. It might be things that need to be reported if you're going to present a paper at a conference, for example. And these set down guidelines, standards, and norms that do guide activity, even if they don't necessarily have a legal basis, because they provide sort of gateways to professional recognition. Then there's also institutional policies and rules, which again don't have the force of law, but if you want to actually work in a hospital, or you want to work in a university, you obviously have to abide by the policies and rules of that institution. So these have significant regulatory effect as well. And then there's sort of general sectoral standards that are often tied to funding or ability to market goods and services. So the National Institute for Health and Care Excellence, for example, the clinical guidelines they establish, can affect whether a particular treatment or device is appropriate for use in the NHS, and we'll get the NHS will be funded for it. There could be voluntary standards or codes, standards laid down by the British Standards Organisation or International Standards Organisation, and general sort of ethics, reports and norms that, again, they don't necessarily have any force, they don't even necessarily have an institutional force, but they can affect the sort of, the way that people think about their work and think about other people's work. So, oh, sorry, skipped ahead one. So I'm just going to very much skate over at least two of these slides because I want to give a general overview of medicine and healthcare, but I've organised it essentially in three ways. This slide really covers the ways in which medicine and healthcare is sort of organised, and the ways in which the actual practitioners of medicine and healthcare are essentially licensed, registered, allowed to do it. So we have, back in the Islamic world in the 8th century, the founding of some kind of licensing of physicians, medical education, systematic record keeping, organised hospitals. In the medieval Europe, you get guilds that you have to be a member of in order to practice, being a surgeon or apothecary. Later, you get the formation of formal bodies like royal colleges for the licensing of physicians and apothecaries, the founding of medical schools, the provision, certainly once you get into the 19th century, of widespread registration, systematic rules concerning qualifications and education, but also, as you can see here, the production of a pharmacopoeia. So this is, these are the drugs that that are allowed to be prescribed, essentially. So starting to set down sort of rules and regulations concerning, what kinds of treatments, what kinds of products are appropriate, and who is empowered to actually prescribe those and deliver those. In this one, we're thinking more about sort of the ethical side, not just of medical treatment, but of medical experimentation involving human subjects. Obviously, in the ancient world, we have the Hippocratic Oath, and then I've sort of skipped a bit to after the Second World War, to some of the codes and declarations that were very much inspired by some of the sort of Nazi abuses of people, the so-called medical experiments that they conducted. So they're setting down the Nuremberg Code, which obviously stressed issues of consent, but also that prior to moving into human experiments, there should be some kind of evidence, and they specify animal experiments, that it is justifiable and safe to actually move to human experiments. Later on, we get the Helsinki Declaration and its various revisions afterwards that stress autonomy, the primacy of the interests of the subject, and later independent ethical oversight and review. Following the United States, which did it a little earlier in the 60s, we have starting the formation of research ethics committees in the UK as an initiative, initially the Ministry of Health and operating in the National Health Service in the late 60s and early 70s. This then obviously spread to universities and other spheres. And then in response to continued abuses in medical experimentation in the United States, we get the Belmont Report issued, which emphasised 4 principles, of ethical research: respect for the individual, beneficence, that that the research should actually contribute greater goods than harms, including to the research subject; justice, if there is a particular set of particular groups that the experimental subjects come from disproportionately, poorer groups, minority groups, and so forth, that those groups should also benefit from the research. So it shouldn't be that you're getting experimental subjects that come from an area where they're not don't have access to healthcare, and so they're not actually going to benefit from any potential results of it. And obviously a stress on informed consent. And more recently, there's been a stress on data ethics, on privacy, and what data is collected, how it is held, how it is used, and so on, which obviously now culminates in GDPR in UK and the EU as well. And then finally, we get sort of to the question of, what actually constitutes proper evidence. So we already talked a little bit about that in previous slides, but what actually constitutes proper evidence for a particular healthcare product or intervention or clinical procedure. So in 1948, we have the first published randomized controlled trial in medicine. So this was initially took place in agriculture and economics, but then moved into medicine. And building on that, the Food and Drug Administration in the United States issued a requirement in 1962 for well-controlled trials for drug approvals, by which they meant randomized controlled trials. So again, there's a sort of start to the idea of this as a sort of gold standard for a treatment being approved. We have the yellow card system starts in 1964. So this is a system of sort of potential reporting adverse reactions or potential adverse reactions. And then sort of more formal medical device regulation starting in the UK, 1969, with the formation of the Scientific Technical Board of the Department of Health and Social Services. So this was operating within the NHS and would sort of test particular medical devices and approve them or otherwise for use within the NHS. So it wasn't necessarily an external regulatory system, but it was within the actual care system itself. And as part of this, this sort of general sort of regulatory system, there was defect and adverse incident reporting and voluntary registration of manufacturers. And then after the Medicines Act 1968, it became enforced in 1971. So this, legislated for the licensing of manufacturers' sale on drugs to ensure their safety, efficacy, and quality. And these two, 69 and 71, are sort of institutional forerunners of what later becomes the Medicine and Healthcare Products Regulatory Agency, founded in 2003. So in the 60s and 70s, so in the previous slide, we were talking a lot more about, some of the maybe restrictions, ethical restrictions on medical experimentation. So, from the 1980s onwards, we get activism for more inclusivity in medical research and expansion of clinical trials. This is in part due to groups that are underrepresented in medical research and clinical trials, and also because of conditions like AIDS, where there is a perceived sort of sluggishness on the part of the medical authorities to actually seriously tackle this emergency. Now, in the 60s and 70s, there had been increasing advocacy of the importance of RCTs in healthcare, Archibald Cochrane, for example, and colleagues. In the 1990s, this was picked up by the evidence-based medicine movement, sort of explicit articulation of it, to create formalized ways of establishing clinical guidelines and creating, what's become known as the hierarchy of evidence, which you can see in the diagram, a figure on the right-hand side there. And as part of this movement, in many respects, the National Institute of Health and Care Excellence was formed in 1999. It was initially the National Institute of Clinical Excellence, hence the acronym. And they were involved in, technology appraisal, developing clinical guidelines, evidence-based, but also using sort of health economics assessments to inform that as well. Is it value for money? Is this product efficacious enough to justify the expenditure in the NHS? 2002, we have the laying down of the UK medical devices regulations, which subsequently built upon are the sort of foundation of medical device regulation in this country now. And in 2003, as I mentioned, the formation of the MHRA. And in the UK and internationally, in this period from the 80s onwards, we see increasing pre-market controls of medical devices and other healthcare products, and increasing post-market surveillance of performance, safety, and so forth, and allying to the new, more and more complex products, there's new and more complex regulatory pathways to cope with that, and as well as this sort of increasing control and complexity for certain, as an increasing number of exceptions, carve-outs, or programs to expedite certain products through these increasingly sort of complex pathways as well. For example, for sort of underserved groups or emergency situations. And so concerning regulation of AI, I'm obviously going to go into a little bit more detail about that. So AI is regulated as AI for healthcare is regulated as a medical device, sometimes known as AI, AMD, sometimes software as a medical device. It's regulated, of course, by the MHRA, who are advised by the Software and AI Expert Advisory Group, mentioned about the UK medical devices regulations. It's a risk-based classification, which is currently undergoing some change due to a general post-Brexit regulatory reform program that the MRHA is undergoing. But concerning AI more specifically, there's a software and AI as medical devices change program underway for the last few years, and the MRHA have already announced, announced their sort of approach based on the government's AI white paper in 2023, and are obviously sort of working out how to sort of implement that in more detail. So turning to the complexities of regulating AI. So the problem you've got is there's lots of different kinds of AI products. There's lots of different domains in which it may be used. So there's multiple, often overlapping frameworks and institutions and laws and regulations that has been described as like navigating a labyrinth or completing a jigsaw. It's also been sort of analogized to being less like a formal garden, as you can see from this one in Paris, and more like a tropical jungle in its sort of complexity and confusion. There's distinct approaches being pursued in different jurisdictions, and there's also shifts within jurisdictions as well, which we've seen most abruptly in the United States in their attitude towards AI regulation. In the UK, you've got many, many different organizations involved in aspects of AI regulation, just in terms of healthcare alone, be it to do with data, approval of products, potential safety risks, and so forth. And different bodies associated with that, obviously most prominently the Department for Science, Innovation and Technology and MHRA. But also, of course, as well as that, there is, some uncertainty about whether there is actually going to be a sort of a law that covers all regulatory aspects of AI. I've just sort of speculated on a name and date there. Originally, this was in the King's Speech last year that the government said they were going to introduce a law. They haven't. They're now saying it's going to be towards the end of this year, but there's some uncertainty about that. There's also the need for international harmonisation, which is managed through the International Medical Device Regulators Forum. There's also the EU as a regulatory superpower, and there's been up to to date there's been an alignment between the MHRA and Health Canada and the Food and Drug Administration of the United States in trying to sort of develop a common approach to AI regulation. But who knows if the FDA is going to still be involved in that going forward due to the uncertainties in the United States. And there's obviously specific regulatory challenges, which I'm going to go to in a little bit more detail, but this comes out of a report of the Regulatory Horizons Council, which is part of the Department of Science, Innovation and Technology, and is tasked with sort of, identifying things that are coming on the horizon, that, frontier technologies, and that we need to start thinking about how we can regulate them now. So they issued this report in November 2022, identified obviously the risks of bias and potential worsening of health outcomes, the failures of generalizability when outside of original training context, issues of interpretability, explainability, and transparency. And they have emphasized, of course, the wider challenge for the regulatory system to remain agile to respond to new fast-moving developments in a fast-moving field, to enable innovation to take place and it to improve health outcomes, while also, of course, ensuring high levels of patient safety. And a key part of this also is not just that that it is safe and effective, but that it is seen to be effective and that it is viewed as a trustworthy technology by health professionals and patients alike. So just as a little summary now of changes in regulatory approaches over recent decades. So this is over the whole of everything, not just healthcare, but covering all sorts of things. And I'm drawing a lot here on the work of Chris Hodges, who's the chair of the Regulatory Horizons Council, who's thought very deeply about regulation, and how it should be conducted and how it's changed over the last 20 years. And the key thing is a change from an emphasis on compliance and enforcement on the regulator as essentially a sort of a police officer and strict rules and fines and so forth, towards sort of regulating through culture, it's called. So a deeper engagement of regulators with the relevant sectors that they're regulating. So not just an adversarial relationship, but a cooperative relationship, and using that relationship to actually define what they and the regulators and various stakeholders, what they actually want out of a regulatory system. So rather than an emphasis on just sort of batting down potential negative impacts, it's an emphasis really on improving performance and standards. So compliance creates a ceiling. You create a sort of box to be ticked it gets ticked, and then there's no incentive to move forward. This is about sort of identifying particular metrics of what the outcomes of everybody, or at least most people in a particular area want, and developing a system and developing standards and developing processes by which those can be continuously improved. And this obviously is a system that relies on trust, because it relies to some degree on, once this sort of these measurable outcomes are outlined, that there is a certain amount of self-regulation. But the idea being is, it's not just trust based on nothing. It's based on the people regulated demonstrating their competence and demonstrating their trustworthiness with evidence of how their organization is operating, so their processes, their culture, and so forth. And those that are able to demonstrate that trust essentially get a large amount of leeway in self-regulation, as long as they continue to provide that evidence. Others that either don't or don't want to, go through that process. There may be smaller organizations can sort of go to a sort of backstop of a more traditional style regulatory regime, or those that are unable to because they're not very trustworthy are also subject to that sort of more traditional style regulatory regime. So it's risk-based in a number of senses. It's risk-based in the sense of the EU AI Act, for example. There's a figure there illustrating where there are certain kinds of activities that are deemed to be potentially more high risk or lower risk, and therefore they're regulated or even prohibited in different ways. Or there is risk based on the sense of the actual regulated organizations. We can identify that you are trustworthy and therefore you're lower risk. You've demonstrated breaches all the time, therefore you're higher risk. But also it may well be that there are certain organizations that, as a result of maybe financial problems they've got into, they might be put into a higher risk category because they're more at risk of breaching regulations as a result. So there's an ombudsman model within this, and an ombudsman model really emphasizes that, so an ombudsman is a part of the regulatory system, but is not a regulator or enforcement agent themselves. They are there as a sort of a point of connection between the regulator, the regulated, and the wider public. They're there to collect data, analyze data, provide data and information to whoever wants or needs it, to provide advice to regulators and regulated, and also to provide a sort of point of complaint by the general public. So the idea here is that there's a key role for actually collecting data on the way that the system is working. So, the measurable outcomes, what sort of levels of complaints are going on. This will become important later on. And there's also been the development of regulatory science. So this is the sort of development of standards, tools, reporting guidelines, and so forth, that can help evaluate the efficacy, safety, quality, and performance of regulated products and services. So you can see, for example, here, Tripod AI and Decide AI as examples of reporting guidelines for models. And then there's sort of an emphasis on allowing experimentation and novelty to obviously not inhibit innovation. And one example of this is through regulatory sandboxes. So a regulatory sandbox is, it's a controlled environment where innovators can test new products and so forth, in allowing sort of certain amount of real world operation, but under the supervision of a regulator, and potentially not with the full weight of existing regulations. The idea being is that obviously they can sort of learn about the product a lot more in this sort of more real world focused environment, but also in a sort of safe environment, and also to inform the regulator about about new developments in the field, but also the actual regulatory system as a whole. So the EU AI Act specifies that every country has to institute, every member state has to institute a regulatory sandbox. The UK has already done a pilot of this with the AI airlock. There's already some sort of findings from that. Some interesting projects involved in that. And as a sort of overall, and there's a link there to Hodges' book on this matter. There's overall an emphasis on regulatory approaches becoming a lot more open-ended. So emphasizing an increase in performance and standards rather than just being based on compliance. And you can see here in the sort of continuous performance improvement of problem-solving model that Hodges replicates, again based on a lot on sort of potentially particularly examples in the aviation industry, about a system establishing what it wants, its outcomes, generating support systems and developing a culture to identify this, having a culture of being able everybody in the system, employees and consumers alike, being able to identify problems in an open, just and safe culture. So not there's not going to be sort of people get in trouble for identifying problems, including problems that they themselves might have caused. The idea being it's better to have this openness about potential problems rather than a culture where people cover things up because they're afraid of the consequences. Then the root cause of each problem, or the systemic cause of each problem, might be identified. That can be remedied, and this can be monitored to ensure to decide this whole system can be monitored to decide if further change is needed, and obviously the system itself can be evaluated. And the key thing here is there's a rejection of a zero-sum conception of regulation and innovation. Innovation isn't just a sort of an obstacle. It is a means to establishing a stable framework for innovation and development in a particular field. In much the same way as laws and regulations can, in sort of stabilizing a field, actually encourage people to invest in either money or their time in a particular area. And another key aspect of the open-endedness is that it's not just a linear process. It's not just, well, you've passed this stage, now we're on to the next stage, then we're on to the next stage. You've passed compliance on each of the stage. It's a much more, there's an ongoing relationship between regulator and regulated, which obviously means that there's greater information sharing, but also sort of less sort of linear and terminal modes of regulation, which in many ways is appropriate to the sort of things that are regulated now. There's not just a one and done sprocket made and that goes out. There's constant change in process and product. So on some of the regulatory challenges posed by healthcare AI, so there's a lot of them as covered in this large slide. So there's a lot of different modalities of AI, a lot of different potential applications of AI in healthcare, be it sort of clinical prediction risk models, generative AI, image analysis, many others. There's a large amount of pace of change in general of the overall field, but also there's a potential for the change in the models themselves. That they might actually update themselves in response to the addition of new data, potentially even new data sources. They might, in some cases, and this is in the future rather than now, they might, actually change their parameters in response to interaction with changes in the data and changes in data and changes in the environment. There's different, modes of validation, audit, assurance, performance metrics, evaluation, and monitoring that might be required. What might be appropriate at one stage of the process, test sort of more software testing approach earlier in the process may not be appropriate later on when clinical effectiveness and clinical safety may be needed to sort of be evaluated. And of course, there's different ways in which different fields in medicine, different areas of healthcare prefer to evaluate performance and monitor performance over time. It may be easier to institute AI, image analysis models, for example, in radiology than it may be because that may fit into their sort of modes of performance evaluation than it might be to implement it in other areas of healthcare. And there's also the fact that there's how do you sort of track drifts? How do you flag drifts? How do you identify these? How do you deal with that? And also, how do you deal with the fact that there may well be an overall improvement in performance for everybody, but it may be one that actually still exacerbates inequalities because those who are already doing well out of healthcare are doing even better than the ones, another group that might have still improved. So how do you sort of measure, how do you balance outcome fairness with processual or procedural fairness? So there's a lot of different factors to consider there. There's obviously issues of data access, quality, security, and governance. Don't know what this new health data research service is going to enable in this regard, but there's still many issues to do with patient data and so forth that are need to be tackled. There's issues obviously of transparency, explainability, interpretability, and again, these are not necessarily straightforward. There's not necessarily one mode of transparency, explainability, interpretability that will suit everybody. Regulators may prefer transparency in the sense of getting, under the bonnet of a model. That was the sort of the Biden administration's approach with it. But certain healthcare professionals may not be that interested. They may be quite happy with a model being a black box, and just as long as they're able to actually assess the performance of the model in real time, then they're happy with that. There's all the manifestation of things that go under the title of implementation. How this actually gets implemented and integrated within existing clinical workflows and systems. There's all the externalities we know about, the potential impacts on environment, labor, maybe exacerbating inequalities, and also just the way that healthcare systems need to be organized to actually implement this, which would include obviously digital transformations, training of all staff in AI literacy and so forth. There's obviously multiple jurisdictions and approaches, i.e. within a country or between them, political and economic developments that can affect this. And then there's the question, of course, is that the level of sort of investment and effort and transformation that is required for this, is it actually worth it in practice? Is it, is the marginal benefit of implementing these AI-based approaches actually worth it over more traditional approaches? But what is needed is scalable, sustainable, adaptable, and heterogeneous regulation to deal with all these challenges. So there's issues of stability. So AI models might be updated with new data, amended to deal with the consequences of new data, adjusted due to distribution shifts, exhibit decline, safety, efficacy, or equity. They might be changed in other ways to improve its efficiency or being able to deploy in particular areas. There might be performative effects. So the way in which a model is implemented in clinical practice actually changes clinical practice, and that itself affects clinical effectiveness and so forth. There's also the issue, of course, that there is not necessarily a final or stable product against which judgments of minor or substantial changes of regulatory purposes can be made. So, obviously all regulated healthcare products change over time and can change over time in their efficacy. But the way in which, for example, a pacemaker or a hip replacement changes over time is more predictable and slower than it would be with, for example, AI models, particularly adaptive AI models that might be implemented, where models actually continuously learn and adapt their performance and so forth. So previous procedures of validation and safety assurance that are just simply based on a state of the product at a point of a point of validation, a validation event, can no longer be relied upon. Validation needs to be an ongoing process, not a sort of simple event or a linear process. And obviously, this needs to take account of, when you're sort of adapting models to particular areas, it needs to take account of the target population demographics and other kinds of data. But there's also, which is, illustrated with this life expectancy image on the right there. But there's other differences in terms of social differences, healthcare differences that can't be directly modeled. And then the question is, how do we include that in our validation processes? And the implication is not just the model itself, but the model development and validation process should be part of any approval process for a product, as well as processes for actually, constant performance, safety, and equity monitoring and flagging of the model if it falls below a certain threshold. And then the question is that how on earth can innovation, implementation, and regulation cope with this kind of continual monitoring? How can it actually be implemented in practice in ways that don't actually exacerbate other kinds of inequalities? For example, between a teaching hospital that may be able to deal with this and a sort of a hospital in a rural or poorer area that might not be. I'm not going to go into too much detail about this, but I'm sort of influenced by some of the AI thinking of Dennis Newman Griffiths here in terms of, again, some of the challenges that need to happen in order for AI to be implemented in healthcare situations. So the governance and regulatory regimes themselves need to be habitually regulated. This needs to take account of the specificity of the AI product and context rather than broad brush approaches. And there's other aspects as well in terms of the innovation process, the need for skilling and open dialogue within healthcare scenarios of the possibilities and pitfalls, and some of the transformations and two-way transparency between producers and implementers as well. So in terms of some of the sort of regulatory responses to the challenge of AI, to the challenges of changeability of other healthcare products before AI came along. These have really sort of emphasized adaptable, responsive, and non-terminal approaches. So in other words, there is so for example, through the US FDA's total product lifecycle approach, which was launched, over 20 years ago, there's greater engagement around a particular product by a collaborative team at the FDA, in the Center for Devices and Radiological Health within it. Big one. So constant engagement with the producers of a particular product, from inception to even discontinuation, so over the total product life cycle. So not just the FDA is there as a sort of regulator, approves it, maybe monitors some sort of adverse events after it, but it emphasizes the fact that through all stages of the process, the life cycle of a product, there is constant information, there is information sharing, there is collaboration between the regulator and the regulated. And there's not necessarily a strict divide between pre-market and post-market regulation, because also there is an emphasis on the ways in which products may change over time. They may be adaptive over time, and to try and create ways in which a product might be adapted without it having to enter the regulatory process all over again, and that would obviously stifle innovation. And there have been, as the diagram on the right, the figure on the right shows, there have been some suggestions about how the total product lifecycle approach could be adapted for software as a medical device, AI as a medical device. Another approach more recently articulated is the establishment of so-called predetermined change control plans. So this is one of the sort of things that the FDA, Health Canada, and the MHRA have agreed upon, in which manufacturers could essentially issue a predetermined change control plan to enable essentially a model to change over time. So it would pertain to an adaptation, refinement, or calibration of a device within set boundaries to the characteristics of a specific patient or healthcare setting, and within the intended purpose of the device. And this would essentially enable it to change within pre-specified bounds that the manufacturer actually specifies. And obviously crucial to establishing such approaches, total product life cycle and predetermined change control plans would mean specifying means of monitoring models in real time, identifying ranges of acceptance performance variables, and developing mechanisms to flag up, respond to potential problems. Now, of course, an issue here is that if a model is able to change outside of these kind of bounds, very sort of restrictive bounds, it would require new authorization all over again, rather than being covered under predetermined change control plans. So there's a number of other approaches that have been tried. So the FDA, until they sort of found out that it was not really legal for them to do so, they had the digital health software pre-certification pilot. And this is again where they sort of had a bunch of potential providers apply to them to demonstrate their trustworthiness to essentially do more self-regulation. And they had a number of these, but it got shut down. But it's an example of some of the sort of more general approaches to regulation being applied in this kind of sphere. There's a number of different AI-specific regulatory approaches that have been proposed, and one is the AI life cycle, which again stresses that it's not just a sort of linear terminal process; that there is an ongoing cycle of planning, data collection, model building, verification, deployment, monitoring, evaluating, and then adapting the model as part of this life cycle. So not just a sort of total product life cycle, which is kind of like birth to death, but an ongoing thing. But again, this will involve a lot of incredibly onerous in a regulatory sense, and in terms of data collection and verification and validation and demonstrating performance, safety, and so forth, as this diagram suggests. There have been a number of initiatives, and I'll just sort of give an overview here. So AI safety summits and various declarations in the last few years in Britain, Korea, and France. China, there's no national law, but there are specific regulations and registration for service providers. I mentioned the EU AI Act. It's quite comprehensive, horizontal risk-based regulation. There's the establishment of EU AI office as sort of coordinator, sort of for sort of a point organisation for the law. The Institution of National Market Surveillance bodies for AI. USA, there's no federal law. There's many state and local laws that have been implemented or in process. For example, with specific things about the use of models in policing and so forth. There's been a huge shift, though, obviously, from the Biden administration, which addressed international collaboration, the establishment of rules and guidelines, particularly around safety and risk, testing of models, transparency of models that manufacturers would have to share with the government, towards a new emphasis in the Trump administration on competitiveness and American leadership in the sphere. and an associated loosening of regulations and overturning of much of Biden's executive order. UK, obviously, there's the importance of GDPR, the RHC report, and the white paper I mentioned that stressed that the regulation should be sectoral and context specific, although there are cross-sector, so that's the EU AI Act again, cross-sectoral principles that are outlined in this table that the MRHA outlined, and the MRHA obviously outlined their own AI regulation undergoing regulatory reform, and we don't know if there's going to be an AI Act. So in conclusion, I'm just going to mention some of the potential contributions of Causal AI. So, there's contributions in the sense of Causal AI being able to model processes of data generation and use. You can see in the diagram on the right here, to be able to characterize where shifts actually might be taking place and why. There's the potential contribution in terms of increasing robustness of models to domain shifts, so improving their generalizability. So this is, again, meeting some of these challenges that Regulatory Horizons Council report identified. There are new means of developing clinical prediction models, new methods to integrate heterogeneous data for clinical practice or for evaluating interventions, for example, randomized controlled trial data and electronic health records or other kinds of data, with a view to sort of generating new ways of generating clinical guidelines based on multiple lines of evidence, and also explainability tools. So practitioners can actually identify perhaps why a model is classifying images in a particular way rather than any other way. And a key thing here is that in all these ways, it's about actually demonstrating trustworthiness, which obviously is a key part of some of the new ways of thinking about regulation that have been instituted in recent decades. In terms of CHAI, responsible research, innovation, ethics, equity, and fairness are at the heart of CHAI's promise, and co-creation and anticipatory governance. Actually identifying what potential problems or issues, or how particular models might be developed implemented in practice, and working with practitioners and patients and regulators ahead of time in order to sort of meet some of these challenges. And through CHAI, we want to sort of help identify, consolidate, and advance best practices, develop guidelines and standards, and help influence the policy and regulatory architecture towards those ends. And so one example of this, and this is my final slide, is through the Regulatory and Policy Forum. So this is a body that we're setting up within CHAI to foster policy development, policymaker engagement by addressing some of these issues, identifying emerging trends, emerging maybe ways of dealing with some of these issues, and contributing to regulatory advancements through collaborative working groups. So the key here is not just for this to be a sort of talking shop within CHAI, but to link between CHAI activities and what CHAI researchers are doing to the wider sort of policy and regulatory actors, and also those who would be involved in implementing particular technologies and approaches. So the Regulatory and Policy Forum will be holding quarterly meetings, but it'll have an ongoing program of work in between those. And also we're holding in Exeter a targeted validation workshop. So this is one of these mooted approaches to dealing with validation of models. We're holding a workshop on this involving all sorts of people involved in implementation, regulation, policy, and so forth on the 8th of July in Exeter. And the activities of the Regulatory Policy Forum will be involved by other bodies within CHAI. The Research Integration Board, which has recently been set up, communities of practice, first of which will be taking place at the end of May, and other CHAI, just general CHAI activities as well. Crucially, I think that there are real opportunities for shaping the regulatory and policy agenda for AI through the co-creation activities of CHAI. And between CHAI and other actors in a wider ecosystem, for example, through the MRHA's programs and regulatory reform, through our RHC studies, there's one ongoing generative AI, many other things that will obviously emerge over the coming years. And I've sort of outlined this to sort of as an invitation for you to get involved, everyone to get involved in whatever CHAI sort of tries to develop in this, in order to sort of feed your work, the insights from your work, and into this process, and also to have your work be informed by these ongoing changes and this is sort of environment that is developing in innovation and regulation of AI. So thank you very much. I thank obviously Steph, Belgin, and Sarah for organising this. Thank you for attending, and obviously we always thank the UKRI AI program, the EPRC, for funding CHAI activities and all the hub activities. Thanks very much.
Thanks very much, James. That was really interesting. I could feel myself nodding along through a lot of that. You're very much preaching to the choir on that one. Um, so I'd like to open up the floor. If anyone has any questions, feel free to put them in the chat or feel free to unmute yourself, whatever you feel more comfortable with.
I'll put my email address in the chat as well, because I appreciate it was on a slide, but that was a long time ago. So
Great, thanks, James. Well, we give people a chance to get their questions together. I just want to mention our seminar next month will be given by Yingzhen Li from Imperial. So feel free to come along to that if you are interested. I'll put a link for a bit more information in the chat if you're interested.
I appreciate I've hit everyone with a huge rapid wall of information there. But
Yeah, well, I have a few questions if that's okay.
yeah.
I noticed so it seems to me that there are sort of these gates in place for in terms of like, reporting the tripod and stuff, but they're, still waiting on that regulatory act. Should we even be using AI in practice at the moment if this regulation isn't even in place yet?
Well, regulations are in place.
Oh,
So these are still sort of under, medical device regulations, and under the auspices of the MHRA. But as with any sort of, healthcare products, the regulatory regime is always sort of evolving, because they're fast changing. I mean, it may seem that, pharmaceutical drugs are not that, fast changing, but there's new classes of drugs and so forth, and new modes of sort of assessing them. So yeah, there is a regulatory regime in place, and there doesn't necessarily need to be a law that sort of covers that, because the existing legislation covers obviously the activities of the MRHA and their activities. But there is obviously sort of, and I will also sort of stress as well that there are some areas with, maybe even like clinical prediction models, where it may well be that you have something that wasn't regulated in the past, that it was just sort of part of healthcare practice. And so it might be covered, for example, by clinical audit within hospitals or within the NHS, but wasn't necessarily regulated. There were sort of risk models that were being used. There were sort of guidelines that are sort of being developed maybe on a local basis or regional basis, that weren't regulated, that actually may end up being regulated if AI is involved. So if anything, it's not that we've moved to a sort of Wild West. It's more that things might actually get up-regulated. That's the wrong term, but they may get regulated more. And something that the MRHA is doing in its regulatory reform program, although a lot of the emphasis of post-Brexit regulatory reform has been on, oh well, now we can sort of remove all these barriers that the EU put in, and an emphasis on pro-innovation and so forth. But in what the MRHA is actually seeking to do is they're actually going to increase the regulation on some of the lower risk categories, than but compared to what they had before. So
great, thank you. Michelle, you have your hand raised. Would you like to ask a question?
Hi, yes, thank you, Steph, and thank you, James. Very, very informative talk. I wonder, well, two questions. Choose which one you prefer. One, whether you could perhaps explain a little bit more about the use of causal AI in regulatory reform. You had a very interesting slide over there, very, very dense as well. So it'd be great to understand. And also, what might be the first jobs that the Regulatory and Policy Forum might tackle, do you think? And thank you again.
thanks very much. So on the first one about, the contribution to causal AI. So I think there are a number of ways in which I think it meets the sort of the challenges laid down by the RHC in terms of some of the issues with inequality, of outcomes, of fairness, of generalizability, for example. I think in those senses is that certainly tools that causal AI might contribute, and obviously that's a very heterogeneous area in itself, might well be ways in which practitioners and people who producing models or implementing models can actually sort of demonstrate in principle or with data the ways in which the model is operating. So the explainability some explainability tools like Rex that I gave an image from may well be able to sort of, at least for practitioners, enable them to trust a particular model. It wouldn't necessarily satisfy a regulator, but it might well satisfy a practitioner that, oh, okay, when it actually says that this is a ladybird and not a butterfly, it's because it's sort of actually focused on something that I would also associate with a ladybird. There's a little bit of, black next to a big bit of red and so forth. And similarly, with modeling the data generation process and actually modeling where shifts might be occurring in the data may well be a useful tool once obviously proper digital infrastructures and data pipelines are in place for actually monitoring models that are actually already been implemented and are already in action. So I see it really as sort of contributing to some of the more general challenges, but also that they might actually be used as tools in implementation and sort of demonstrating trustworthiness. And in terms of the Regulatory and Policy Council, it's going to go the way I think that the constellation of practitioners that we get involved in and the challenges that arise through CHI activities steer it. I think I wouldn't want to sort of specify that it's going to go in certain directions. I think initially we're maybe looking at this sort of targeted validation approach and how that might be implemented. Thinking about the modes of innovation and regulation implementation there, because that's also come out of CHI activities as well. So the work of the Manchester Spoke in particular, but it's very much open-ended to what the wider environment it wants to look at, and also what is arising out of CHI activities and what CHI people want to look at.
Thank you.
Thanks very much for that question, Michelle. Does anyone have any other questions for James?
Hi, I might have a quick one also. Hi, James. Thank you for the presentation. I also wonder, because you mentioned that without the EU in the UK, we may expect even stronger regulation activities, so or stronger rules in a sense, if I understood correctly. And I wonder, or just generally, what's your thoughts on all these procedures and regulations around data access? Because usually this is an important tool for people that work on new methods and on new methodologies, and that seems to be quite a big hurdle in general. It takes time. It takes a lot of filing forms and etc. And I wonder if, from the regulatory perspective, can we expect these to be easier over time or actually worse?
I think in response to the first part about I wouldn't say that the rules in general are going to be sort of more stringent, but there's certainly talk from the MRHA that sort of the lowest risk activities might be regulated a little bit more strongly, but in general not necessarily. And I think there is an emphasis on sort of situational context specific regulation, and so there's not necessarily going to be a broad brush. This is going to be stricter. This is going to be looser, but. So as long as it obviously meets these principles of the government that, well, the previous government laid out, that the current government is continuing. And so on the second point about data access, I think one of the major issues is maybe not necessarily in terms of regulation. I wouldn't want to speculate where the regulation and governance and that direction is going to go, but I think it's actually on the sort of actual infrastructural aspects and the sort of bureaucratic aspects, and this announcement yesterday of the formation of this health data research service that's between, I think, the UK government and is going to be hosted on the Wellcome Genome campus in Cambridgeshire. I think is intended to provide a kind of single point of access to data, and therefore, at least in a bureaucratic sense and maybe infrastructural sense, the path is going to be eased, even if in a strict regulatory sense it's not necessarily going to be. And it may well be that is enough to actually ease the path for a lot of it, because I don't see certain regulations about what can be done or with particular forms of data, or whether particular forms of data can sort of exit trusted research environments. That's not necessarily going to change, but yeah, the infrastructural aspects might change, and that may actually solve some of the problems that researchers encounter.
Yeah, thank you.
Thanks for your question, Damien. We're coming up to 2 o'clock now, so I just want to thank James again for your time and for such an interesting talk. If you'd like to contact James about this, he did put his email in the chat, so feel free to get in touch with him. And yeah, thank you all for coming, and hopefully we will see you at next month's seminar.
Thanks.
Thank you.
Thank you.